Hello, my name is Vance. I'm a third-year medical student from Drexel University College of Medicine. Thank you for tuning into my presentation on diagnosing laryngopharyngeal reflux, a comparison between 24-hour pH impedance testing and pharyngeal probe or Restech testing. First, what is laryngopharyngeal reflux or LPR? LPR is an extraesophageal form of gastroesophageal reflux that may cause chronic throat clearing, cough, globus sensation, hoarseness, and sore throat, secondary to mucosal irritation of the larynx, distal vagus nerve stimulation, or laryngeal cancer. LPR may be asymptomatic and is commonly referred to as silent reflux. Accurate diagnosis of LPR remains controversial. Now, how do we currently diagnose LPR? Patients most often are diagnosed by clinical presentation of the aforementioned symptoms, as reported on a validated reflux symptom index in conjunction with laryngoscopic or videostroboscopic findings, including the reflux finding score or RFS. Impedance testing reportedly has more accurate diagnostic utility to identifying reflux episodes in liquid, gas, and mixed forms. Restech, minimally invasive transnasal oropharyngeal probe, can measure pH and detect exchanges in the pharynx in the form of liquid or aerolized droplets. It has been reported to have improved sensitivity compared to impedance testing. Esophageal manometry also has been used as an adjunct to pH testing to evaluate lower and upper esophageal sphincter tone and function throughout the esophagus. Now on the left, we see a picture of the less invasive Restech probe, and on the right, the more invasive impedance probe. What was the purpose of our study? To compare the diagnostic utility of the pH monitoring via the impedance testing compared to the pharyngeal testing. How did we go about studying this? We did a retrospective review of 87 patients who completed a reflux symptom index survey and stroboscopy within 60 days before or after undergoing simultaneous double probe, impedance, and Restech testing. Reflux finding score was determined by 4 blinded observers. We looked at total events at different pHs, time spent in reflux and in which position, and symptoms experienced. We calculated Pearson correlation coefficients to assess relationships between RSI, RFS, and test results from impedance and Restech tests. A student's t-test was used for comparing means. So what did we find? In regards to the patient's symptoms, there was a positive correlation between the percent time spent upright and supine reflux with RSI. Restech correlated better with total patient symptom scores, including cough, heartburn, burping, and clearing of the throat. Restech finding score a composite of percent time below a certain pH threshold, the number of episodes in which the pH dropped below a certain threshold, and the duration of the longest episode also correlated well with the symptom index. When we looked at RFS score, we found that RFS correlated with the Restech Lyons score. However, there was no correlation with RFS in any other parameter in our study. When we compared impedance testing and Restech, we found that Restech was able to detect more percent time in reflux for total, supine, and upright reflux, as well as detect longer event times than impedance testing. Restech was able to detect more events in the range of pH 5 to 7, as well as total events compared to impedance testing. However, impedance testing detected more events in a pH below 4 compared to Restech detecting a pH below 5. We also looked in our study at the WU score, which is a new score for determining LPR based on machine learning. 74 of our patients had a WU score determined. 37 of these patients had a positive WU score. Statistically significant positive correlation between the WU score and upright line score was observed. There was also a significant positive correlation with the WU score with percent time in total upright and supine reflux, as well as longest time spent in reflux. There was no correlation between the WU score and the remaining parameters. When we look at our first table, we see impedance and Restech detection counts, where we can see that Restech was superior in detecting total reflux events, while impedance testing was superior in detecting pH below 4 compared to a Restech detecting a pH below 5. When we look at our second table, we look at impedance testing and Restech testing and the amount of time spent in reflux. We notice that Restech is superior in all four categories of longest event time, percent time spent in reflux, and total upright and supine reflux. In our third table, we look at the positive correlations that were observed in our study from comparison of RSI and impedance upright percent time in reflux to comparison of the longest time of reflux at a pH below 5 and the WHOOS score. So what were we able to learn from our study? Restech was able to detect more total events than the 24-hour pH impedance test. However, the 24-hour pH impedance test detected more events at a pH below 4, and this might be due to some of these events not reaching the pharynx. Restech detected longer reflux events and a longer time spent in reflux, and this might be due to the lack of an effective clearing mechanism in the pharynx. In our cohort, the duration of the reflux events appeared to play more of a role than the number of events regarding the patient's symptoms. And this may be because the longer the time of reflux, the more tissue injury the patient will experience, but further research is needed to investigate this speculation. We also looked at the Lyons score and found that it correlated with the RFS, while no other parameters in our study had a significant correlation with RFS. And other authors have suggested that this raises the concern about either the validity of that scale or the validity of the reflux test. Patients may respond differently to acid exposure, and individual tissue inflammatory changes are unpredictable, which might be the factor that helps explain the lack of relationship between the number of acidic events and RFS. It is also possible that modification of the tests or their interpretations might improve sensitivity, as appears to have been demonstrated with the Lyons score and the WHOOS score. In conclusion, the amount of time of events correlated with symptoms better than the number of events. RFS correlates with the Restech Lyons score. The impedance test was able to detect more events at a pH of below 4 than the Restech test, possibly because there might have been more acid events below than above the upper esophageal sphincter, while Restech was able to detect more total events. Restech recorded longer event times than the 24-hour pH impedance test. Both Lyons and WHOOS score improved the sensitivity for diagnosing LPR. I'd like to take a moment and thank the many people who helped me along the way. I first want to thank my mentors, Dr. Sataloff and Dr. Alnouri. I also want to say thank you to Dr. Ferster and Dr. Lyons, who helped with determining the RFS score. I also want to give a big shout out to fellow medical student Jin Park, who helped me out throughout the entire project. Thank you for taking the time to tune into my presentation.